Welcome to today's IDEA webcast titled All Together Now, Realizing IPE at Academic Health Centers. It's now my pleasure to introduce our host, Dr. Eugene Anderson, who is the Chief Policy Officer and Managing Vice President of the American Dental Association. Dr. Anderson leads the IDEA Policy Center, which provides evidence-based research and analysis, collaborative advocacy, and thoughtful leadership. The IDEA Policy Center works through 4 targeted portfolios, including access, diversity, and inclusion, advocacy and governmental relations, educational research and analysis, and institutional capacity building. We're pleased that Dr. Anderson could join us today and host today's webinar. Dr. Anderson, the floor is all yours.
Thank you for the introduction, Bobby. For today's webinar, we're fortunate to have Drs. Denise and Jeffrey Stewart with us to share their expertise on interprofessional education and its incorporation into an academic health center. Dr. Denise Stewart serves as Senior Associate Dean for Clinical Affairs and Professor of Community Dentistry at Oregon Health and Science University School of Dentistry. Dr. Stewart also serves on the Interprofessional Initiative Advisory Committee and as an interprofessional education facilitator. Dr. Jeffrey Stewart serves as Interim Chair and Associate Professor in the Department of Pathology and Radiology at the Oregon Health and Science University School of Dentistry, as well as Chair of the OHSU Interprofessional Initiative Steering Committee and the University Curriculum Committee. Thanks so much to both of our experts for joining us today. Today's webinar will enable participants to identify key challenges to implementation of the IPE Collaborative Core Interprofessional Competencies, outline methods used to address key IPE challenges, and investigate if and how dentistry is different than medicine, nursing, pharmacy, and other health professions in the implementation of IPE collaborative practice. So, Dr. Stewart, what can you tell us about your new academic health center building in Oregon and why IPE is essential to your mission?
Thanks, Dr. Anderson. Yes, let me tell you a little bit about Oregon Health and Science University. OHSU's 96,000 square mile campus hosts more than 875,000 patient visits each year. The schools of dentistry, medicine, and nursing, and the College of Pharmacy are educating over 3,000 students and more than 1,000 residents. We strive for these dentists, pharmacists, nurses, advanced practice nurses, physicians, physician assistants, research scientists, and others to work at the highest level of their training and ensure they are well prepared to deliver collaborative, patient-centered care.
In 2009, 6 national education associations of schools of the health professions, including IDEA, formed a collaborative to promote and encourage constituent efforts that would advance substantive interprofessional learning experiences to help prepare our future health professionals for enhanced team-based care of patients and improve population health outcomes, hopefully at reduced cost. These organizations that represent higher education in allopathic and osteopathic medicine, dentistry, nursing, pharmacy, and public health created core competencies for interprofessional collaborative practice to guide curricula development across health professions schools. Health professions educators and providers across the globe recognize widely the need to prepare health professions learners for team-based, patient-centered, collaborative practice, and interprofessional education has been accepted as the means to cultivate the collaborative workforce required by rapidly evolving health systems. Health profession students who participate in IPE, which is defined as when students from 2 or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes, These students are more successful at collaborating in clinical settings and promoting positive changes in healthcare systems that lead to enhanced patient safety and quality improvement. These system-level changes are necessary to achieve the triple aim goal of lower costs, better patient experience, and healthcare outcomes. The now decades-long desire to advance interprofessional education, however, is challenged by the model of programmatic silos that has been entrenched for decades in academic health centers, where nursing, medical, dental, pharmacy, and other health profession students traditionally follow similar but rarely intersecting paths to graduation. Dr. Anderson, I believe we have a poll question for our audience.
Yes, first poll for this webinar. We want to hear from all of our participants. How advanced is the IPE program at your institution? A, no IPE program at this time. B, in the planning phase. C, some level of IPE activity. And D, IPE is a core part of our curriculum and activities. Bobby, can you just give a few more instructions for our participants on the poll?
Sure. In a moment, there will be a poll that is going to pop up on your screen. And when that poll pops up, all you have to do is click the option that is best for your particular situation. That poll should be on your screen right now. Please go ahead and select the one that's right for you.
Very close. Let's give one more minute. We love a 90% or higher response rate. All right, we'll go ahead and stop well, we have a couple more coming in. Let's see if we can get, okay. Bobby, go ahead and wrap up the poll and show the results, please.
All right, and we're broadcasting those results right now.
Okay, great. So it looks like we've got a majority of our participants have some level of IP activity, 59%. We've got 16% where IP is core. And then we've got 12 planning phase and 11% where at this time no IP program at their institution. Dr. Stewart, your thoughts based on the feedback from our audience today?
Yes, it's very interesting, Dr. Anderson. It's not too far from the findings from a recent study that was published in JDE in August. Maybe our participants are already familiar with this, but the Association report on 20 years beyond the crossroads, the path to interprofessional education at U.S. dental schools. In that publication, Drs. Pallotta, Cook, Anderson, and Valakovic reported that 90% of the schools offer some kind of IPE experience. But within those 90%, only 58% had a formal university-led and promoted IPE program. So I think our poll holds true to what we've seen in the survey of 2014.
Okay, great. And I think one of the things that's great in that feedback with this poll is we know that we have a number of folks participating from allied dental programs, so we were able to capture a sense of what's going on at those programs as well. For any listeners who recently joined the webinar, welcome to our program. Today's webinar, hashtag AHCIPE, altogether now realizing IPE at academic health centers is being presented by the IDEA Policy Center, which supports IDEA's role as the voice of dental education. My name is Dr. Eugene Anderson. I am the IDEA Chief Policy Officer and Managing Vice President. To learn more about the IDEA Policy Center, we encourage you to visit IDEA's website at www.idea.org and click on the Policy tab. Be sure to stay connected for more news on important policy efforts and upcoming webinars. With us today, we have leading experts in IPE, Drs. Denise and Jeffrey Stewart, live with us from Oregon Health and Science University School of Dentistry. Before we continue with our discussion, now is a perfect time to find out just how many people from all over are participating with us. So, Bobby, can you handle that for me, please?
Absolutely. And on your screen at this time, you will see an attendance poll. Simply enter the number of people attending at your site in the space below, and we'll give you a few moments to go ahead and do that. We'll leave this poll open for approximately 30 more seconds. About 15 seconds remaining in this attendance poll.
Bobby, can we give a few more seconds, just get a few more people counted?
We'll leave it open for a little bit longer.
All right, great. Thank you, Bobby. I think we also have a map that just shows just where our audience is located. Can you show that briefly, Bobby?
Absolutely. And on your screen at this time, it shows a map of where all of our registrants are joining us from today.
Oh, great. So we have people from all over the U.S., as well as our friends to the north in Canada. Really excited to have everyone with us. So let's get back to our topic. So Dr. Stewart, what are the key challenges in implementing IPE into an academic health center?
In 2011, the Interprofessional Education Collaborative, or IPEC, expert panel published the core competencies for interprofessional collaborative practice. One of the key aspects of this publication was the identification of 6 key challenges to the adoption of interprofessional education. You see the 6 challenges here. Our goal today is to provide you with methods that have been used at OHSU to address these challenges.
The first challenge in the IPEC report related to institutional level challenges. At OHSU, all of our schools and programs are committed to health and science education. Given this focus and lack of other non-health science-related programs at OHSU, the leadership of the institution understood the critical importance of interprofessional education and preparing the future health workforce to practice at the top of their license. In order to ensure the importance of this agenda for the institution's future, interprofessional collaboration became a strategic priority that was integrated both vertically and horizontally at the institutional level. The university's strategic plan strengthens the institutional commitment to collaborative practice and interprofessional education and actually embeds the terms interprofessional and collaboration into the strategies developed for the plan's 6 goals. For example, one of the 6 strategies under one of the goals is to develop and reward faculty who lead interprofessional education and collaboration within and across missions. Similarly, one of the 4 strategies under one of the different strategic planning goals states, educate a clinical and scientific workforce that creates new knowledge and addresses the health of populations in an interprofessional environment. Interprofessional initiative. Why do we call it the interprofessional initiative? Including interprofessional collaboration in the strategic plan also provided a solid foundation to implement institution-wide interprofessional initiative changes. This was launched by our provost in 2012 to bring together the schools of dentistry, medicine, nursing, College of Pharmacy, and other OHSU healthcare programs, including physician assistant, nutrition, and radiation therapy. The use of the term interprofessional initiative rather than IPE was meant to signify that all schools and programs would work collaboratively, not only to forward interprofessional education and collaborative practice, but also in multi-professional and program-specific ways to improve education, collaboration, and efficiency. This latter aspect of the initiative was important to encourage students and faculty to realize innovation and opportunity as we began to take on the numerous challenges and changes that would be necessary.
The next challenge that we are going to talk about is the lack of institutional collaborators. So at OHSU, collaboration is a core value and spans across departments, programs, schools, and professions. For many years, the OHSU Center for Ethics in Healthcare was a leader in early engagement of faculty across the institution in an integrated approach to ethics in healthcare. Other collaborative examples include the joint Doctor of Pharmacy degree that is awarded by OHSU and Oregon State University. And more recently, OHSU and Portland State University are developing a new School of Public Health. But what is critical is putting the resources behind these initiatives. Our provost supports FTE for faculty members on the IPI steering committee and provides administrative, evaluation, and assessment and faculty development support. Thus, collaboration has been incentivized and resources have been allocated that begin and continue the initiative.
The culture of collaboration is essential in the development in partnership throughout the state. OHSU is developing an interprofessional campus for rural health, which will in fact be launched in just about one short month at the beginning of our fall term. Our OHSU campus for rural health brings together all healthcare programs to improve quality and access to health in rural environments and to educate an interprofessional rural healthcare workforce. In fact, as recently as yesterday, the OHSU University Curriculum Committee approved a new course that will be a component of the Campus for Rural Health. In this course, all of our students who are spending time on their rotations in the various locations of our Campus for Rural Health will participate in a community-based project. This is a project in which the communities themselves identify a healthcare need, and working in conjunction with the community, interprofessional teams of our learners, while on their rotations, will participate in various aspects of these projects in an effort to improve the population health in those rural locations.
The next key challenge in implementation is that of practical issues. In order to have an interprofessional curriculum, the students have to be able to work and learn together. The various schools have different curricular delivery systems and methods at OHSU. When IPI began in 2012, there were 14 distinct academic calendars. Through considerable effort and the leadership of the provost, there has been a common calendar developed that ensures dedicated time for IPE. OHSU programs now schedule within the framework of a 4-year calendar with common term start dates and requirements for credit hours. Beginning this year, all students will have available time on Mondays and Wednesday afternoons and evenings to engage in IPE coursework that will be taught across the university for required and elective courses. A common interprofessional orientation process is another way we've attacked these practical issues. It is in place, and it allows the students in interprofessional groups in their orientation to learn about university resources and services. The OHSU orientation helps establish an institutional identity and sense of community beyond the professional identity developed through each program's unique orientation. Another practical issue was developing shared educational space and building capacity to bring learners and faculties together in situations that are educationally optimal. In June of 2014, the Collaborative Life Sciences Building, which you see depicted in the slide, the CLSB as we call it, was opened on OHSU's South Waterfront. The CLSB brings together medical, dental, pharmacy, physician assistant, and other professional health profession learners together with Portland State University biological science students into a shared space that is combining the resources of multiple universities to enhance science and education and research opportunities. Within the CLSB, there are 20,000 square feet of interprofessional simulation space available to students, faculty, and community providers. The CLSB has created an immediate environment for sharing and collaboration. Students are no longer in their own buildings or isolated spaces, but utilize space as needed for all types of educational experience within this building.
Another practical issue that's not bulleted on the slide, but we felt was an important challenge that we needed to overcome was a practical issue related to approval of courses that were being designed and deployed for interprofessional education. At our university, we have now a university-wide OHSU curriculum committee, which by charter is tasked with the review, approval, and evaluation processes for interprofessional courses, both required or elective, intended and designed to include qualified learners from 2 or more professions. The OHSU Curriculum Committee includes members of the Interprofessional Initiative Steering Committee, the group of faculty with primary responsibility for developing and overseeing implementation of the interprofessional initiative, but also faculty members from each of the school's curriculum committees and also student representatives from all of the different programs. The next challenge cited by the IPEC report related to faculty development issues. At OHSU, in addition to interprofessional faculty populating the various committees and work groups that develop and implement interprofessional education courses, nearly 300 faculty members have participated as faculty facilitators for our Foundations of Patient Safety and Interprofessional Practice course that is required of most OHSU health professions' early learners. For example, first-year medical, physician assistant, and dental students, accelerated baccalaureate nursing students, second-year pharmacy students. Interprofessional faculty members participate in training sessions before each of the Foundation's course sessions to review a detailed facilitator's guide and to discuss cases, learning activities and objectives, and best practices. The facilitator training has uniquely brought together faculty in an equitable situation to learn about, from, and with each other, and about each other's professions and professional programs. We have also learned from feedback from faculty that this is a very rewarding experience for them, one of the most important aspects being the opportunity for them to participate in these development activities, but also to facilitate the sessions for the students as a team of at least 2 interprofessional faculty facilitators. Finally, I just wanted to mention an assessment survey instrument that has been developed here at OHSU. This is referred to as the Assessment for Collaborative Environments for Interprofessional Education, or as we refer to it, the ACE tool. And this has been validated in clinical settings throughout Oregon that will include OHSU learners. Clinical education sites that can use the ACE tool for internal team development based on the current level of teamness and opportunities for effective collaboration. Sites can engage in more extensive team development through co-created, site-specific programs aimed at enhancing the role modeling of collaborative practice to IPE learners.
I see that we've gotten a question that we're going to pop in now and talk a little bit about. Some successful IPE programs require medicine to be centrally involved and engaged. What's the best way to engage medicine and make them excited about working with us? We've been fortunate at OHSU that all of our health profession schools have been very excited about being engaged. I think one of the things to point out is all the developments, and certainly the person posing this question, I'm going to use his name, Dr. Scott DeRossi, is aware of the movement toward everyone understanding the very tight link between oral health and overall health. So I think that's one way to engage our medical colleagues, particularly with dentistry as well as the other professions. We can only do this well if we all work together.
And we'll touch upon this in just a few minutes, but also the accreditation requirements that have now been instituted in the medical education programs is a driver to encourage our medical colleagues to participate with the rest of us in interprofessional education activities. The next key challenge in implementation of interprofessional education reported in the IPEC report related to assessment issues, assessment of competency. Since the 2011 IPEC report noted that the assessment instruments to evaluate interprofessional competencies represents a next step, considerable work on standardized assessment metrics has been ongoing. Within the OHSU IPI, feedback is gathered via faculty and student surveys, narrative reflections following IPE sessions, student peer review, and focus feedback groups. Students also take an objective examination upon completing our Foundations course. To meaningfully assess whether OHSU students are IPE CP competent, however, university-wide learning objectives applicable to all learners were developed. In early 2013, the OHSU graduation core competencies were adopted by all of our schools and programs and now apply to all OHSU students. These shared competencies now provide measurable outcome objectives to be met prior to graduation. One of the core competencies that was strongly addressed in all of our schools and programs centered around issues of patient safety. This provided the support for the development of our Foundations of Patient Safety and Interprofessional Practice course that I mentioned earlier. Within this course, filled with content pertinent to learning how to provide safe patient care, students also begin to learn about the elements within the 4 IPEC competency domains mentioned in the IPEC expert panel report. We're going to just show some of the learning objectives for each of the different sessions of the Foundations of Patient Safety and Interprofessional Practice course, highlighting not only the learning objectives that relate to patient safety, but also where the IPEC core competency domains are highlighted within these learning sessions. So in our first session of this course, as you can see, the IPEC core competency related to roles and responsibilities and understanding the expertise of other health professions is an important learning outcome for this particular session. We also just have the students be able to describe the contributions of the various health professions to patient-centered care and safe patient care. On the bottom right, you can't read it, but this is just a little pocket card that we developed as a component of the OHSU Interprofessional Initiative. This is a card that we give to all of our students, and in fact, many of our faculty have also requested copies of this card. It provides some of the issues, some of the definitions and theories that relate to cultures of patient safety, error models, and it also provides students with certain definitions related to patient safety. But I think most importantly, this is meant to be carried by students when they're in clinical situations, and it's a little card that they can refer to. One of the components is a series of communication tools that are effective in use in describing a culture of patient safety that our students can reference when they're on their clinical rotations.
Session 2 learning objectives. Before I start this, I do want to say it was my pleasure and opportunity to be to be on the work group that helped develop a lot of the exercises and learning materials for this patient safety sessions and the Foundations course. So that was a wonderful experience of working with colleagues in medicine, nursing, physician assistant, pharmacy, and others for us to come together and decide and develop the materials that we wanted our students to learn and to be able to apply and practice. So the specific learning objectives here do go into some of the things that Jeff started to mention, but teaching the students about error, how to characterize error, and the difference between at-risk behavior and reckless behavior. It also really focuses on this idea of relationships, that these are issues that are human factor affected, as well as having to do with the healthcare system complexity. That those things work together or sometimes at odds, and we have to understand those relationships. It also highlights the demonstration of teamwork skills, and teamwork skills are one of the IPEC domains. This session also looks at interprofessional communication. This is one of the best components of the session in that the students role play techniques that help them speak up as a member of a healthcare team when patient safety is jeopardized. And that's actually one of the tools and methods that's on the card that Jeffrey described to you earlier. The IPEC domain here is, of course, communication.
The third session in our Foundations course accomplishes the learning objectives that you see on the slide now. This is a session where we dive very deeply into analysis of adverse events, and students learn strategies not only to reduce errors, but also to be able to understand why particular errors might occur. In particular, through case studies, our students perform root cause analyses to understand the importance of that technique in analyzing adverse events. In this particular session, you can see that we also emphasize collaboration and teamwork. And in the next set of learning objectives for this particular session, you can see that this is the area in which we begin to introduce the last of the IPEC competency domains, which is ethics and professionalism. Students in this session, again through role play and case studies, begin to learn how to resolve ethical tensions, including situations of conflicts that might arise in interprofessional teams. They go through an analysis of an ethical problem, and finally, we again have them reflect on the unique cultures and values of the various health professions.
So before I go to our next challenge, I see some questions that have been posed to us, and a lot of them are asking the same thing. Can we get a copy of that pocket card? So we'll work with Dr. Pilata to provide that as a handout that can be distributed to the group post-session. So yes, we'll make sure that we can share that with you. Thank you for your interest in that. The final challenge in implementation that was cited in the IPEC report had to do with a lack of regulatory expectations. I'm pleased to say that this challenge is one that is well on its way to being overcome. Most of the accrediting bodies for healthcare profession programs have included IPE in the accreditation standards. While the standards vary by accrediting body, at OHSU, all are met within the OHSU Interprofessional Initiative, the IPE curriculum, and the OHSU Graduation Core competencies. In addition, OHSU identified IPE as one of the 4 core theme indicators for Northwest Commission on Colleges and Universities Regional Institutional Accreditation. This has helped us integrate IPE throughout schools and programs and generated systematic assessment and reporting. Our participants are no doubt familiar with CODA Standard 2-19, which states that dental graduates must be competent in communicating and collaborating with other members of the healthcare team to facilitate the provision of care. So in dentistry, our accrediting body has recognized that preparing our students not only by providing them with interprofessional education, but maybe moreover, preparing them for interprofessional practice is an essential responsibility that we have. So next we're going to another polling question. So Dr. Anderson?
Yes, we are going to ask the audience the following. Which of these is the greatest challenge for your school or university regarding the implementation of IPE? A, difficulty with collaborating across health profession schools. B, practical issues such as calendar, schedule differences, course credits, faculty pay. C, agreement on IP curriculum and or assessment. Or D, lack of institutional commitment. Please select the best answer. Bobby, go ahead.
I was just going to mention that, as you can see on the screen at this point, you will see our poll is in front of you. Just go ahead and select the one that is best for you in this particular question. We have about half of our respondents. We'll leave this open for the remaining half to go ahead and respond to this particular poll.
All right, Bobby, let's give 5 more seconds so a few more of our participants can respond. Okay, if you could go ahead and close it, Bobby, and show the results.
And those results are being broadcast.
So it looks like the top challenge that our participants give is practical issues such as calendar, schedule differences, course credits, faculty pay. 57% stated that this was the greatest challenge, followed by 20% difficulty with collaborating across health profession schools, and 17% lack of institutional commitment. So my question to Drs. Denise and Jeffrey Stewart, if lack of institutional commitment is a smaller share of the responses, why do we still get caught up on the practical issues?
Many of those practical issues in our experience here have been overcome, albeit not completely, but overcome to a degree based on strong leadership, not only from the provost office, but from the deans and associate dean level individuals of the different schools and programs. Under the leadership of the provost, this group is brought together monthly with the Interprofessional Initiative Steering Committee, and these very difficult practical issues are discussed openly, and there are strategies developed to develop solutions for these practical issues. And again, this is one area where strong leadership really is necessary for these types of issues to be overcome.
I think in thinking about why is the lack of institutional commitment a lower percentage, it's really hard to get people talking together about the institutional commitment when they can't see past these practical issues. I think people maybe philosophically agree with a commitment to IPE, but until you get down to the, if you will, nitty-gritty of these practical issues, and through the course of working them out, you really develop that collaborative approach, and the institutional commitment becomes, then can become the priority and the message that's being sent across the institution.
And I should note that a few of our participants suggested an all of the above option. So for some, there certainly are a number of challenges that still persist. So Dr. Stewart, do you have any thoughts as we move into the final question? Is dentistry different than medicine, nursing, pharmacy, and other health professions in the implementation of IPE collaborative practice?
Before we answer that question, Eugene, I just wanted to state briefly in terms of a summary as we look at an image of two of our health profession students participating in our Foundations of Patient Safety course in their interprofessional small group. I think changing an academic health center culture to accelerate the integration of interprofessional practice and education is really complicated, as we've discussed. This has required OHSU to overcome significant challenges. Systematically addressing each of the 2011 IPEC report challenges, however, has afforded us an opportunity to accelerate curricular development and the culture change required for the new and sustainable model of collaborative practice and interprofessional education to develop. You posed a question about whether or not dentistry might be different than medicine, nursing, pharmacy, and other health professions in the implementation of interprofessional collaborative practice.
Yes, there are some differences that are often pointed out, and I would, while I give my thoughts, we'd like for the audience to please submit your own thoughts about the answer to this question, and we can be collecting that information just in your chat questions. I want to reference an article or a publication from the Center for Health Professions at UCSF from 2011. Mertz, Linder, and Dower were the authors on collaborative practice in American dentistry, practice and potential. They made a number of points in there that really address our question of is dentistry different? And I'm going to point out three of those. While medical practices have moved away from solo practice settings more rapidly, dentistry still has a significant number of practitioners in solo practices or small group practices. This is changing, and we see a great deal of this change in the Northwest, where we have a lot of large group practices, and a lot of our students will graduate and go into a group practice setting. So this is changing, but this difference does impact interprofessional education, and especially interprofessional practice. Another point that's made is that dentistry, as compared to medicine, has fewer specialties and allied health careers. So the scope and overlap of practice within dental professionals is less than medicine. So we still have these kind of discrete boundaries around what is the role of individuals within the various specialties and allied health professions that seems to have blurred more in the medical side. Another big issue is the impact of the Affordable Care Act and what is going to change in our payment system. As we move toward more payment being based on outcomes of care, dentistry will need to change. The use of diagnostic codes, which many dental schools have already adopted, monitoring treatment outcomes and patient health, again, which I think dental schools are leading in this aspect, and moving away from payment based entirely on numbers of procedures completed. So those are some of the things that we think of when thinking about this question, is dentistry different? So I'm looking at some of the comments from others. And one of the things that's brought up is it's difficult to think about how to collaborate with other providers. So we're going to we can address that in a couple of ways. The ability to collaborate when you're in practice may be helped by some concepts of using distance learning, telemedicine, and then engagement within the community. So even though the practitioners in perhaps their solo practice or smaller group practice, they still have opportunity and reason to be collaborating with the other health professionals in their region or that are engaged in the treatment of their patients.
I see another couple of questions that ask how can programs that are isolated, educational programs that are somewhat isolated, how might they begin to become involved in interprofessional education opportunities? We have faced that here at OHSU in the sense that we have some of our nursing students that receive their education on campuses very different from our main campus. Therefore, we do have a population of nursing students that are quite a bit isolated. We're beginning to try to provide opportunities for those students to participate in interprofessional education activities by really looking outside of our institution and looking geographically in that location for innovative opportunities. Very often we've found that while we are looking for partners to create interprofessional education programs, there are programs that are also looking for partners, and it's just a matter of being able to creatively think about who potential partners might be, and very often can sometimes unexpectedly find a very willing partner to develop interprofessional education opportunities.
Sorry, I just ahead there.
So we have time for some additional questions, and our experts have been answering questions all along, so I encourage any other audience participants to send us some questions if you have them. I have a couple of questions for Drs. Denise and Jeffrey Stewart. How can an academic health center bridge the gap between IPE at their campus and the goal of collaborative practice outside the campus? I think this relates to the questions you already mentioned about a local dentist for one of our participants saying that because they and most of their colleagues practice in solo or small practices, they really are, in essence, in isolation. So how can the academic health center bridge that gap? Engage the community.
I think each institution will have unique opportunities. We're taking a stab at this through the establishment of our campus for rural health that was mentioned recently. We feel this is a wonderful opportunity for not only our institution, the Academic Health Center, to engage the practicing community in a very interprofessional and collaborative way, but it's an opportunity for our learners to also participate in providing health care, in our case, in very rural settings, but in circumstances that are being intentionally designed to expose these students to collaborative practice and to expose them to clinical sites that we have assessed with our ACE tool to ensure that our students will be learning and practicing in practices where they are working as high-functioning teams, and that these sites have a great deal of teamness, as some have referred to it. So that's one of the ways that we're attempting to bridge the gap that you described between our campus and the healthcare practicing community throughout the state.
All right, thank you. Well, related to that, you all are in a very innovative and interesting part of the country as it relates to just the transformation of healthcare in the U.S. And so I've been reading about Kaiser in the Northwest and their partnership and inclusion of dental practices. Are you familiar with that, and can you say something about the implications of that type of healthcare system?
Yes. Kaiser Permanente Dental Associates has been a part of the Kaiser Permanente healthcare system for many years. This is not a recent innovation. It's something that's been in place for quite a while. The identification and recognition of the importance of oral health and overall health has been evident in the way they operate for, as I said, quite a long time now. So in addition to the basic integration, if you will, and collaboration amongst the dental providers in the Kaiser system and the other providers of care, as well as social work and other important professionals in the overall team approach to the health care for the patient, they also support a research institute and a research endeavor that investigates these relationships. They're really also taking advantage of some data mining and analyzing of outcomes of care of patients and how they are impacted by the relationship between oral health and general health. So that's been their goal, and they've been dedicated that for quite a while and are able to see improvements in patient outcomes because of it.
Thank you. Well, we are at the end of our webinar, so I want to thank Drs. Denise and Jeffrey Stewart for their time and their expertise. For us here on the East Coast, this is a lunchtime webinar, but I realize this is a breakfast webinar for Drs. Denise and Jeffrey Stewart. So thank you for waking up and being a part of this webinar. I want to also thank everyone for joining us today, and I want to turn it over to Bobby from KRM with final comments regarding evaluation and CE. And also look to the ADIA website for information about the next webinar, which will be in October. Bobby?
All right, thank you very much, Dr. Anderson. And that is going to conclude our presentation today. All together now, realizing IPE at academic health centers, brought to you by ADIA and presented by Dr. Jeffrey Stewart and Dr. Denise Stewart. And your ADIA host was Dr. Eugene Anderson. We hope that you have enjoyed the presentation today. On your screen right now, you will see information regarding CE verification forms and the steps to do so. All you have to do is complete that online site roster at attend.krm.com/22852. That is a typo. You do not need the .w at the end of that. So once again, that is attend.krm/2282. Upon completion, you will receive an email with a link to the online evaluation. That form must be submitted by Thursday, September 17th, 2015, using the event ID 22852 and the email address you have entered into the online site roster. You can download a copy of your CE verification form. Of course, if at any time you need help, you can contact KRM customer service at 1-800-775-7654 or email custserve@krm.com. Also, be sure to follow at ADIA Web on Twitter and continue the conversation using the hashtag AHCIPE. Once again, you can follow us at ADIA Web on Twitter using the hashtag AHCIPE. We do appreciate you joining us today, and that is going to conclude our program. Today's program is copyright in 2015 by the American Dental Education Association, all rights reserved.